Are you okay? Yep, lovely. Okay, so good evening. Just welcome to the Paediatric Brain Tumour live discussion panel. Thank you very much for joining us. We've got three experts on our panel this evening. We've also got some families that will be watching from the comfort of their own home, so just welcome to you. I know a lot of you have filled some questions over the last couple of weeks, and you've put them onto our Facebook page and contacted us directly. We've been inundated with questions, which has been fantastic, but we won't be able to address everyone individually, unfortunately, tonight, but we will endeavour to do so later on in the week. So do bear with us, because every question is important that we do want to answer. I'd like to introduce to you Deborah Crossan, who is parent to her daughter. I'm hearing myself. So I'm going to introduce to you Deborah Crossan, Michelle Smalley, and David Walker.
I'm back. I suffered a browser shutdown.
Has anyone got the video open in the background? Because I'm hearing myself come back, so that's causing a bit of a delay.
Not as far as I know.
No, that's fine. Michelle?
No.
No. David?
No, I've got nothing else on.
Okay, lovely, excellent. So if I could be kind of, if it's okay to go to Deborah and just kind of give your background and as to why you're here tonight and on our panel, please.
So I have a little girl who was diagnosed with a medulloblastoma when just after her 3rd birthday, and she was when basically she'd been sick for a while, being vomiting, headaches, and then her balance went. So went to the GP a couple of times and then just took her to A&E and didn't leave A&E until we had an answer. And so they found the medulloblastoma, which was removed, but it had metastasized all over the rest of her brain. So then followed lots of chemotherapy, radiation, and then a year's chemotherapy. And just before the last dose of her year's chemotherapy on a routine scan, the tumour had returned in the primary site. So we entered another ream of treatment, and she had some radiosurgery followed by more chemotherapy. So 2.5 years later, she is 7 years old, and she is alive and kicking in a new way.
Amazing. That's an amazing little girl. She came to our family day on Saturday, got a goodie bag, because it was very pleased with her. So yeah. she's a delight. Thank you, Deborah. We'll come back to you in a minute to talk a little bit more about your experience, if that's okay. I'd like to introduce to you Michelle Smalley, Dr. Michelle Smalley, if you'd like to say a little bit about yourself, if that's okay.
Hi. Yeah, so I'm a clinical psychologist who is funded by Latch, which is the Welsh Children's Cancer Charity, based in Cardiff, but we serve all of Mid, South and West Wales. And I've been in post 18 months working just with the children in Wales who are affected by brain tumours.
Lovely, very much, Michelle. Thank you for joining us. And last, not least, is Professor David Walker. If you'd like to introduce yourself, please, David.
Yes, I'm David Walker. I'm a paediatric oncologist, and I work in Nottingham at the Queen's Medical Centre, and also within the University of Nottingham, where I do research and teaching. And I'm part of the Children's Brain Tumour Research Centre there, which has been established since 1997. And is trying to promote research. In this particular context, I suspect that the strongest collaboration I have is with the Brain Tumour Charity in running the Head Smart campaign, because that was something we developed in conjunction with the Brain Tumour Charity and its forerunner, and launched that in 2011, and it's still ongoing. In fact, on Friday this week, we're having a a kind of review meeting to plan our next strategy for the next 2 or 3 years. So it's an ongoing live campaign which has had significant impact, but needs to do more.
Yeah, absolutely. And you are the clinical lead for the Head Smart campaign, and we will be talking to you a little bit more about that in a minute, if that's okay. I've introduced myself. I'm the chair of this evening's panel. My name's Alyssa Costa. I'm the Children and Families Worker at the charity. I support families both emotionally and practically following a diagnosis of a brain tumour in children. I really organise family days. We send out brainy bags to children and young people affected, and really any support that a family needs, then we will offer. Tonight we just want to start off. We have like I said, we have so many questions, which has been just brilliant, and quite a wide range of questions. But we've kind of identified the topics that that have been running through all of the questions, and they include early diagnosis, research and treatment, and late effects. And I'd like to come to you first, Deborah. Sorry, David, if that's Head Smart, and your experience, just to hear about really what your thoughts are about early diagnosis and how things have got better and have progressed.
Yes. Do you want me to speak or Deborah to speak?
Sorry, David, if that's all right for you to speak.
Yeah, because you just broke up a bit then, so I didn't.
Yeah.
So I mean, Head Smart was really set up in response to experiences that we were having in meeting newly diagnosed patients with stories of significant delays. And people were very upset. And people were so upset they were actually speaking to their members of parliament, telling their stories in the press. And I was working at that time with a neurosurgeon called Jonathan Plant, who's now a barrister. But we were seeing patients, and he made the point that the only way you can make a diagnosis of a brain tumour is to do a brain scan. And the delays were all related to delays that led up to, first of all, an awareness that a brain scan would be the right thing to do. And then the second thing was actually getting it done. And the technology was available, but it wasn't easily accessible. And because it wasn't easily accessible, a lot of the doctors weren't thinking that they could really do that test, and so they might either wait and see or do another test, and then the other test wasn't always terribly informative. And so we decided that one of the things to do would be to try and raise awareness amongst the public and the profession about the symptoms of brain tumour, just as a kind of band-aid to try and help people, because we felt that that's what we could do. We did think about trying to train every doctor in the country to be a paediatric neurologist, but we decided that that wasn't possible. So raising awareness was the thing we could, because everybody's trained. They just need to be reminded that these symptoms in this age of child may be something wrong in their head, and if you want to understand what's going on in the head, then a brain scan is a good thing to do. It doesn't mean to say they're definitely a brain tumour, but there could be something going wrong in the head. And so we launched this campaign in 2011, and at the time we had information that the time to diagnosis was around between 10 and 14 weeks. In 2006 it was 14 weeks. In 2011 it was about 9 or 10 weeks. And then we launched the campaign, and then it's come down to 6.7 weeks. So that means it's significantly speeded up the diagnosis. Particularly, the doctors are acting more quickly than they were to start with. So they're taking less time. And so the people are getting into the scanner faster once the symptoms are appreciated. What's not changed as much is the awareness in the public. They don't seem to be getting to the doctor faster, because that's really in their hands. That's in our data. Of course, individuals have different experiences, as we've heard earlier on today.
Yeah, I mean, it's the Head Smart campaign, like you said, it's been so successful. We've had very recently 5 separate families get in touch to say that their child was diagnosed with a brain tumour because they had a Head Smart card.
Well, that's fantastic, because we did say that that would happen, and we hadn't heard about it until the last few months, as I understand it.
Yeah, it's been really recent, and I just think actually it just shows that it takes time, but it's working and it's showing the results now. And like you said, the fact that the time from the symptoms to the diagnosis has really reduced is just brilliant.
It'd be really nice to tell those stories in a kind of consistent way, to tell people how the cards are now working, because you've distributed over 1 million of them now, haven't you?
Yeah, absolutely. We've done that, and I think, like you said, it's just getting people in the public, teachers, and healthcare professionals to just be aware of the main signs and symptoms, and not to scare, and not to cause alarm, but to just actually give them confidence to go to the doctors, and like you said, take that first step. Deborah, if I can come to you, did you, when you were worried about your daughter and concerned about her, were you aware about any signs and symptoms of a brain tumour? Was it something that came into your mind when your daughter was poorly?
No, not initially at all. I mean, it was around November time, and she started vomiting. So when she was still vomiting after maybe 4 days, and I took her to the GP and said, I know what you're going to say. It's November. It's really normal for kids to be like this, but when should I be worried? And she said, well, all her vital signs seem to be okay, so just go away again. And then she stopped vomiting, and then she was kind of okay for a little while, and then she started again. And so we took her back to the GP, and again he said, it was a different GP, and he said, it could just be, it's just time of year sort of scenario. But it was when very quickly she started saying she had pains in her head, and then she started losing her balance, and that was really within a 4-week period. So her, I suppose in one sense, from the time she started being sick until the time of diagnosis, it was only 4 weeks, but because her symptoms got incredibly bad very quickly. But she'd obviously had the tumour for an incredibly long time, I'm assuming, if it had metastasized. So but yeah, GP wouldn't have ever, I don't think it crossed his or her mind. It was only even when we went into the hospital, actually in A&E, they did her vital signs, and they were like, well, yeah, we'll have to do a scan, but we're not going to do it right now. Come back in a week.
So there was no urgency there?
No. And that was on like a Thursday, and then on Sunday it just got so bad we knew she was really not well. So.
And do you feel that things have improved over time? Have you seen that actually the awareness raising of the Head Smart campaign, for example, has brought it into people's minds in the public?
Yeah, without a shadow of a doubt, absolutely. Yeah, and I think there's definitely still a huge amount of fear around, the brain tumour. And I think it's, I think, as David said, the scan is the only way to diagnosis, and it's often it feels like money is one of the reasons what stops people getting access to these things, because it's a really big deal having a scan, and particularly for a small child who then has to probably go under a general anaesthetic. But yeah,
I think that's the point, Deborah. Actually, it's not really money. Because actually the scans are quite cheap. It's the organisation that's needed for a child to have a brain scan.
Yeah,
it's just not straightforward. You can do a CT scan, which takes literally 20 seconds, but you need to put a drip up, and not all children like having needles put in, so you need to prepare them. And I think that sometimes inhibits people from taking a step, because people will do a chest x-ray without any difficulty. All you have to do is go into the room, take a big breath, and have your picture taken. But a brain scan is more complicated. But I'm working with Dr. Deneen, who's a radiologist, a specialist in brain radiology, and he's designed a much shortened scan sequence for screening children in the MR scanner, because the MR scanner normally will take an hour or 45 minutes to get us picture, because it takes a long time. But he's created a shortened version, which I think will be advertised soon to speed up, so the scans are less arduous for the children, because no child likes lying still, particularly under the age of 8. They tend to be quite active, and so that is the problem.
Yeah, absolutely. And we have on a near daily basis, families getting in touch with us to say that their child was diagnosed too late, or later than they had, obviously would want, from the early onset of symptoms. And one of the questions was, why are doctors not noticing this? And quite often we say, and want to know, interested in your view, is that in a doctor's lifetime, in a GP's lifetime of their career, that they will probably see just one child with a brain tumour. Would you agree with that, David?
Absolutely, and if that, actually, I think the way that the general practice arrangements are going, there are many more people working part-time, and so their personal experience is even less. And so I think this is a really important observation, because it's not really about individuals, it's about the system. Because individuals function within a system. And in the past, we all thought, oh, the doctor made a mistake. What we need to do is think about the system and make the system more sensitive so that any doctor working within the system is helped. Because if you just focus on the doctor, then everybody has their experience, and the defense is that I'll only see one or two of children in my whole professional lifetime.
Yes.
Whereas we're all trained to diagnose rare and common things in medical school. And it's really, how do we remind people of the rare things? Because if we rely upon seeing, well, what we normally see is croup, asthma, eczema, then that means doctors are only experts in those three conditions. That's ridiculous. That's not what doctors do. So it's about, how do we create the system to help the doctor be reminded of what this collection of symptoms might be. And I think there is already quite a lot of work going on amongst researchers in general practice to try and address that.
And do you think it needs to go back even as soon as when they're training, to really plant that seed about the effects of signs and symptoms?
There's no doubt that the work we've done in preparation for HeadSmart, we published a paper about the symptoms. It's been heavily used in undergraduate training as a very good source of information for education and training. So I think that's already going on. And we've created web-based training packages, what they call computer-assisted learning packages, which are being very heavily used in general practice training. So I think we've already done those things, and they're part of the strategy. I think what we need to do is create that all GPs work with computers on their desk. And that's the way that they can be reminded, because then they open up their system for the next patient. It always knows how old they are. And because it's this patient's date of birth is, so it always knows that. And quite often, once he types the symptoms into the computer knows what the symptoms are. So it wouldn't be impossible for the computer to generate the list of common serious problems and include in that the cancer diagnoses at that age group, because they're very different. So brain tumours mainly occur under the age of 8 in childhood, and then they become less common. Leukemia mainly occurs around the age of 3 or 5, and then it becomes less common. And then other tumours start to occur in the older age groups. So I think a reminder based upon age. And the other thing is family history. Often family history can be quite helpful.
Yeah, absolutely. Thank you. I just want to move to Michelle and just ask about your experience really of early diagnosis and late diagnosis, and how many children that come to you where they have not been diagnosed soon enough, and what your really views are about what more can be done to raise awareness. Oh, Michelle? Okay, we seem to have lost Michelle for the minute. I'll move on now to our next subject that's been presented to us in the questions. Is about research, and it's something that it's been in the media quite a lot recently with regards to the Asher King story, and talking about treatment and access to that treatment. We at the charity, at the Brain Tumour Charity, are very passionate about funding treatment. We're currently funding 27 grants and have committed 3.5 million to research over the last couple of years. I'd like to come to you, Deborah, and to ask, has your daughter benefited from any new treatments, or do you feel that more needs to be done in terms of research?
Well, I think there always needs to be more done into research, and you know, I guess I'm only starting to become aware of how, I guess, poorly funded brain tumours have been. It wasn't, I think, when Ella got diagnosed, I kind of went to ground. I didn't do huge amounts of research or whatever. It was just about how on earth are we going to get through this. And it's only now I'm starting to realise how, just how poorly funded they've been, and compared to a lot of the other cancers. And in terms of Ella's treatment, I suppose I guess now, you know, I wasn't aware when Ella was having her treatment about maybe proton therapy. I don't know whether that would have been appropriate or not. However, I do feel like we had radiosurgery for her, and that isn't always an option for other people in other parts of the country. So I don't know. I'm not reflecting too much about her treatment, because actually it is what it is. I can't change it. However, we're now living with the damage that's been caused by it. So I guess looking to the future and looking to research to try and limit those damaging effects that the treatment has on children, for me, would be where my passion would lie, really.
Yeah, and we'll come to that in a minute, because that's again been something that's come to us through the questions, and something that people are very passionate about. Michelle, hello. I think we've got you back now.
Yes, you have.
No, it's fine. All these Google Hangouts, it's, you know, gets a bit much. We were just talking about research and about treatment. And I guess in your role, you do work with a lot of children who are affected by a brain tumour, and dealing with the late effects, which we'll talk about in a minute. In terms of treatment, which do you think, I mean, what are your views on radiotherapy, chemotherapy, and proton beam?
Oh gosh, you're asking probably the wrong professional there on that one. From a psychologist's point of view, you know, we have to screen all our patients, preferably before they start treatment. There can be some side effects, as we know, more so commonly associated with radiotherapy, but even proton therapy has its risks. Can anyone else hear me?
Neither can I.
Oh, I can hear you. Okay. Our tech guy will sort that out, but you carry on, Michelle, for now.
All right.
So she's lacking the equal sign.
That's what it is, lacking the equal sign.
I've had to switch to my mobile phone because my laptop's died, so it might be my end. But yeah, so no, I was just saying, from a treatment point of view, you know, as psychologists, we're there to support the team and the parents and the families from an assessment point of view in terms of preparation for treatment and any of the possible side effects. You know, every therapy's got its pros and cons, and you know, what regime people go on is dependent on their condition and what the clinical team think is most appropriate.
No, absolutely, thank you. And David, I'd like to come to you, because we had a parent get in touch with us to ask about DIPG and why so little is known, and why children can't be offered anything in addition to chemotherapy. And just wanted to ask you really what direction you feel treatment is going in towards to treat DIPG and other paediatric brain tumours.
Well, DIPG, which is diffuse intrinsic pontine glioma, is a very problematic problem. There's been a real serious problem ever since I started doing neuro-oncology. And there's been no lack of effort to try and investigate new ways of treating it. There have been many drug trials, there have been many trials studying different doses. If I was to say why we're in the position we're in, I think the main reason is that tumour does not primarily respond to the treatments that are currently available. The radiotherapy is only temporarily effective in most patients. Chemotherapy has not been shown to be effective despite extensive trials of different drugs, even in maximum doses. And so this is a very resistant tumour, and it's not dissimilar to the sort of problems we have with high-grade glioma in adulthood, which has a very quite a similar story. It is also unique to children. Diffuse intrinsic pontine glioma doesn't happen in adults by and large. And the final thing is that it was decided a number of years ago that it wasn't in the children's interests to biopsy these tumours, because nobody had any treatment that worked, and nobody was going to do any different according to the results of the biopsy, and the biopsy was a hazardous procedure, particularly in the days before we did stereotactic biopsy, which is with a needle.
Yes.
And so a view pervaded that nobody would do a biopsy, which was okay for the children at the time because I think it was well thought through. But the unexpected consequence of that is that no one's really had access to tumour material to do research on as a result. And so progress with research has been slowed up by limited access to tumour material to try and understand the biology of this disease. In the last 2 or 3 years, however, there have been significant discoveries. 2 things. First of all, they've found that different tumours, different patients have different biological categories of diffuse intrinsic pontine glioma, determined by the region of the brain it arises from. And the second thing is that there's some of the molecules that control the way the cells divide and replicate their DNA have been found to be mutated, which may give us a target that we haven't had before. So these are 2 new areas of research that are actively being worked on, and everybody's put it as their top priority. So I work and collaborate and meet with people from all over the world discussing brain tumour research. And this is really a hot topic at the moment. The whole question of diffuse intrinsic pontine glioma is a hot topic. And people are collaborating in networks across the world, sharing ideas, sharing tissue, and working as hard as they can to try and find a new method of treatment based upon a new understanding of the biology. But
so things like you say are moving forward.
Yes, I think so. I think the trouble is, for the people who come into the clinic today, there isn't a trial of a new drug in the UK at the moment. So that is quite a negative thing. And the way people explain that to people makes them feel extremely distressed.
Yeah. I mean, at the charity, it's worth mentioning that we're funding 2 programmes at the moment, one with Professor Stephen Clifford at Newcastle University and Professor Richard Grundy at University of Nottingham. And like you said, it's something that we get asked about quite often, about DIPG, and thank you, because that's really interesting what you've just said. And one thing I'd quite like to ask as well, David, while we're talking about research and treatment, is about clinical trials. And do you feel that I think I might know your answer on this one, but do you feel there needs to be more available for children, and what are your views on clinical trials?
Yeah, I mean, I think first of all, we've done a lot of clinical trials. I was chairman of the UK and the European Brain Tumour Trials Committee, and we've done an enormous number of clinical trials. Unfortunately, children with brain tumours are relatively rare, and so therefore the downside of that rarity is that doing a trial takes quite a long time, because it takes time to recruit enough patients to answer the question in a way that means that people can believe that the answer is as true as you can make it. Because the more patients you have, the more confident you become that the result you have is accurate. There are ways of doing trials to generate ideas rather than prove treatments that require fewer people. And I think we haven't been doing enough of those. And the discussion that's going on about how to test possibly new drugs in small numbers of people is something that hasn't been explored, and I think it needs to be discussed a bit more. And that's about generating some information about experiencing the use of existing drugs for new purposes in children whose disease has come back and needs to try something new. And I think that is still a problem. And maybe the experience that Deborah's had would be relevant to that.
Yeah, thank you. I'd like to move on now to talking about late effects and living with a brain tumour. Really, I think I'd like to come to you first, Michelle, if that's okay. Can you hear me okay?
Yeah, I can.
Excellent. And really, can you hear Michelle?
No.
Okay, we are still working on that, so please bear with us. We hope that will be fixed soon. Michelle, I know that all of you, children and young people who are diagnosed with a brain tumour, face multiple challenges every day, and living with the late effects has a huge impact on their lives, not only emotionally but school, education. And I'd like to ask Michelle, what late effects that you come across quite regularly while working with children and young people?
Okay, yeah, so I think you've probably touched on the three main areas really. The emotional effects, the kind of the older children who are kind of just hitting the transition period into school and have that kind of, oh, what just happened to me for the last couple of years, who pop out the system after treatment and are trying to make sense of the journey and what's happened the last couple of years of their childhood. So you have certainly those types of effects. And adjusting back into what we often phrase as the burden of normality. So expected to go back to school, expected to get on with life, and that can be difficult for the parents and the children as well. So often we do quite a bit of work with the families, just trying to look at how we transition slowly back into school and slowly start to kind of tease away from having very intensive kind of acute medical support, because that can be quite scary for parents and quite unusual and strange for the children, who can sometimes become almost institutionalized from being with adults and within hospitals for so long. And then again, that leads probably nicely into the educational kind of side effects, where again, you know, you can get left behind with your peers, so you might have ended up having to go back a year, so your friends have kind of gone on to school without you, or social relationships have developed, and you've kind of got left out from your social peer group. And then also just catching up as well. Whilst a lot of children do have access to ward-based schooling, it's not quite to the same curriculum, the same topics that are followed by the actual mainstream school that the child's within. So we often have quite tricky challenges in getting children back into school and catching up with the curriculum. And here in Wales as well, we've got a lot of dual language speakers. So sometimes myself and our paediatric oncology outreach nurse will have to go into schools and make recommendations that maybe dropping one of the languages is the best way forward, and advising schools on how they might need to change the curriculum a little bit. And cognitively, yeah, there can be sometimes effects, sometimes 6 months or a year later down the line, or maybe they don't even transpire until children are kind of reaching their adulthood years. So having regular access to neuropsychological assessments or education psychologists who can keep track of cognitive development is really important.
And I think, I mean, we've worked together, Michelle, and you know, I know the support that you give to families is invaluable, but I also know it's not available, you know, everywhere, and not every child and young person that has had a brain tumour and has a brain tumour has access to the support that you give. And I know a lot of families that get in touch with us are desperate for that support. You know, and I think within education, there's a real struggle for schools to understand the effects that, you know, a brain tumour does have. And I find that there's quite a lot of schools that they look at a child who has had a brain tumour and they look fine, they look absolutely fine, but they don't have that understanding of fatigue, concentration, behaviour. What advice would you give, and what support do you give, you know, that for children who are living with the late effects of a brain tumour?
Okay, so I mean, you're right. The access to clinical psychologists and neuropsychologists is quite limited. You know, there is a small cohort of us around the country. In fact, Professor Walker lectured to us on our first meeting back in May. So we are all trying to liaise together and set up some kind of a gold standard almost of neuropsychological provision. But it's not just clinical psychologists that can deliver this. You've got place specialists, you have got education psychologists. Again, I can only speak for Wales, but you know, that resource is limited in different areas as well. You know, we've got play therapists that are available in the community. We've got charities such as yourself that can provide, obviously, that kind of support. But I think it really is, wherever you go, you have got the support of the oncology outreach nurses. And I think, you know, certainly in our area, those nurses will go out to schools, will do the transition meetings, so going from primary school through to secondary school. Sometimes those notes of this child had a brain tumour when they were 4 or 5 doesn't go with them to secondary school. No. And you're right, they do look normal. There's nothing to tell that this child had a brain tumour and therefore might have subtle problems with learning, or, you know, quite obvious problems with learning in some rare cases. And so it's really important to keep in contact with your oncology nurses, because they're the ones who've kind of got that child's history in their head, if you like, and can do that kind of liaising and try and get the support in every local area.
Thank you, Michelle. I'd like to come to Deborah and ask about your experience, Deborah, about in Ella being in school, and what frustrations you've had, if any.
Oh, plenty.
I thought so, but
well, I didn't get to hear any of what Michelle was saying, so
oh, sorry.
I look
Okay.
forward. No, that's fine. I look forward to hearing about it. But
she was talking about the support that she offers to young children, young people in schools, and also the fact that I was saying that there's not much support throughout the UK. It's not the same across the board.
I mean, I think in one sense, I'm maybe not lucky is the right word to use, but I guess just before Ella was diagnosed, she had been attending. She was due to start attending a preschool. So she was kind of in the school system. So they had a preschool attached to the school. So she was on their radar. So we were incredibly lucky that from day one of Ella starting school, she had full-time LSA support. And within the first year, if not before that, she had a full statement. Now, which was amazing. I know there's many families out there who are still fighting for that support. What that gave us was, I suppose, the school were completely floored. They didn't really have any idea what they were dealing with, and I think a lot of the time they looked at her and they saw fragility and worried about her physical state rather than actually thinking about thinking about her cognitions and her learning and all of that. And I suppose they've worked hard at trying to understand what a brain tumour is, and they've gone, they've had some training and stuff like that. But it is a constant battle trying to get that understanding across, trying to, I guess to a certain degree, unfortunately, schools are under a huge amount of pressure to tick boxes, and children with brain tumours, and particularly, well, I can only talk about Ella, she doesn't fit any of their boxes. She's always outside of that, and so it's just constantly keeping in touch with the school. It's a full-time job in itself, but I do
count myself a constant battle.
I guess it is, and the support is out there, but sometimes it's just not knowing where to turn, and it's just it's just hammering doors down trying to find the support that's out there. And I think just lastly, I would say it's just because it's on so many different levels. It's physical, it's cognitive, it's emotional, and because of all of the side effects, her hearing, all of that sort of stuff. There's so many different levels of support she requires.
Yeah, thank you. Michelle, I'm just coming back to you about the late effects of such as fatigue and behaviour. I know we have a lot of families that get in touch with us and with concerns about their child's behaviour, having had a brain tumour or living with a brain tumour. And what sort of support would you give to a family, and who would you refer to other than yourself?
I guess the first thing you've got to understand is you need to do a comprehensive assessment of the behavioural problems, because not always is behaviour going to be related to what we'd consider an organic reason for behavioural problems. So sometimes it can be, but often it can be a child's emotional state, and the only way that they can express themselves is through a certain type of behaviour. Younger children sometimes also regress in some of the skills they've learnt, so toilet training, speech, all those sorts of things, how to express themselves, all those kind of skills can regress as well. So sometimes it can appear like it's naughty behaviour, such as maybe, not making it to the toilet on time, but actually it could be those skills have regressed. So it's about doing a thorough assessment with the team, so having a kind of psychosocial approach to these problems, and thinking holistically about where the child's come from, what the problems are, what are the other factors that could be contributing to that. And I guess we're very lucky in our team because we've got play specialists on the ward, but we've also got a play therapist who goes out to children within schools and their own homes. So we've got a lot of kind of multidisciplinary support within our team, so we can all work together. So I might, for instance, work with the parents and give them some strategies and think about how we need to think about what factors might be causing these problems, whilst the play therapist might be actually out with the child, helping them to express their emotions in a more positive way and learning different coping strategies. So it's very difficult. Every area is so different with the resources they've got, but I think really it's a case of getting a good psychosocial assessment of the problems to work out what could be causing them and how we might be able to tackle them.
And I think you just hit the nail on the head. I think it is very much about having a multidisciplinary approach and working together. And I know that when I've visited many of the hospitals in the UK and the primary treatment centres, and where there is a model like yours, actually it works really, really well, and I know that families feel much more supported because they know they have someone to talk to and someone to contact, whereas other hospitals, they don't feel they have got that main contact, and that is a huge frustration for them. And I think when they have a low-grade brain tumour, for example, they're told they've got a low-grade brain tumour, it's a case of watch and wait, and they go back into school, but they're still living with those late effects, and they just feel very isolated. And I don't know if that's something that you have come across yourself with the family.
Yeah, I mean, as much as we're well resourced, I think we've still got areas where we could do better, and with the best team in the world, there are certain families that are going to feel that they're hanging on a limb, watching and waiting, like you say, and it's how you deal with that anxiety and that day-to-day, black cloud following you around. And, we try and support as many parents as we can, and, we try and make contact with every newly diagnosed family so that they at least know where I am and how to contact me. But again, I'm part-time, and I'm sure a lot of psychologists and other clinical teams aren't full-time staff, so it's very frustrating for families when they don't feel that they've got that support when they need it, or after treatment's finished. Because they've had such an intensive support and intensive network of treatment, it can sometimes feel like you're left on a limb, because it's like, you're well now, off you go and get on with life. So, I think there's still a lot we can do, and, acknowledging that we are aware of that. It's just, where do you aim your limited resources, I guess?
Yeah, absolutely, absolutely. David, I'd like to ask a filter question that we've had from the parents, saying that many children suffer from hydrocephalus due to their tumour and chronic headaches due to late diagnosis. Is there often a specialist neurologist who can help with the headaches due to the hydrocephalus? Is that something that is standard that someone can access and that a family can access when they have concerns?
Yeah, if you have hydrocephalus and have headaches, it's if you relieve the pressure, so you need a surgeon rather than a neurologist. And once the pressure is relieved, the headaches generally go away.
Yeah.
I mean, people do get headaches for other reasons, but if you have headaches due to pressure, if you relieve the pressure, they go away.
And other questions that we've had, thank you for that. Other question we've had is fatigue normal for somebody who has a brain tumour, who's living with a brain tumour? Is that something that's quite common?
Anybody who's had a serious illness, who's been treated with chemotherapy, fatigue is a very common symptom. Anybody who has a brain injury of any sort, fatigue can be a common symptom. Fatigue is a sense that's generated within the brain, and if the brain's not working optimally, then fatigue is a common symptom. So it's something with which people have to cope, and it fluctuates in its severity. And tiredness is obviously relieved by good quality rest, careful pacing of yourself, so that you don't try and do too much. And of course, that's not the natural way for children. Children are normally high energy. Some aren't, but them are high energy, and they want to do things, and they don't. Tiredness is not normally the things that holds them back. So there's no doubt that brain injury and treatment or intensive treatment for chemotherapy can lead to fatigue.
And I think for a lot of the families that get in touch with us and adults, that is their main frustration, that the fatigue, that actually schools don't understand the need children have when they are fatigued, and also businesses where they're at work, and actually they do need, that needs to be managed, doesn't it, really effectively, and be understood.
It does need to be managed, and it can recede as they finish the treatment and recover. It often takes about a year to fully recover from intensive treatment. And you have the initial physical recovery and the hair grows back, but actually the psychological recovery takes a significant length of time, because it's not just the young person, it's the family round about them, because they've all been keyed up about the treatment, and it takes a while for the family to readjust itself to a more normal existence, and for the anxiety levels to fall a little bit, and people have a bit more confidence. And of course, it all comes rushing back every time somebody does a scan, and so all the sense of worry starts to recreate itself.
Yeah, absolutely. And like Michelle was saying, it's about that black cloud hanging overhead. And I know I spoke to Deborah on Saturday that Ella's just had a clear scan, and there's times, like I suppose, Deborah, where the build up to that is huge, isn't it? It's a real stress.
Yeah, and I think I'm not sure you ever get used to it. I definitely think it becomes much more of a common, or becomes part of, you have to make it part of your normal life. And I think now it's a deeply subconscious thing that I'll notice, you know, a week or two before I'll start being a little bit tetchy, or maybe a bit more tearful, or maybe just a bit more sensitive. And you know, someone will say, "Oh, Ella, do a scan." I'm like, "That's what it is." You know, it's not necessarily. It's just, I guess it's something that we really try hard to just keep out of the picture, because life has to carry on, and I don't want it to dominate. We've still got another 3 years of scans, and I don't want it to dominate our life. But it's a very real thing, you know. And yeah, I'm hoping that the black cloud turns to grey, and then floats away at some point.
Yes, absolutely. Absolutely. Lovely way of putting it. And I think, you know, it will reassure so many families that are watching tonight that it's normal, you know, and I think that's the really important thing, that, you know, I want people to, you know, hear what you've been saying, and actually, and I know they'll relate to it. And I think that goes back to the family days, you know, that you came along on Saturday, and families that meet each other. It's just reassuring, isn't it, just to get that support. And one thing I wanted to ask was going back to the support side of things. You know, it never goes away, and it was, you know, 4 years ago that Ella was first diagnosed. What support did you get, and what have you had since, and has it kind of fluctuated? Do you always feel you have somebody that you can go to?
I think at the beginning it was just head down. We were in hospital all the time, and I was 4 months pregnant when Ella was diagnosed, so had a baby in the middle of it, and the support came. We were supported by a children's charity that was recommended to us. We were put in touch with them by our social worker, and that was amazing. And then Ella's, I guess the threat of her, I don't know how better to put it, but I suppose she was no longer seen as an acutely ill child. She moved into the chronic phase, and the minute that happened, they kind of withdrew their support, and that was, I have to say, the most incredibly frustrating and hard time, because as a family you're left with all of these hospital appointments. Nothing had changed in our lives in terms of, okay, she was more stable, we were out of hospital, but actually all those hospital trips still were regularly happening, and it didn't make any difference. Nothing had changed for us as a family, and that was incredibly difficult. And I guess it was around that time that I became, and this is awful, but I didn't know about the Brain Tumour Charity when we were first diagnosed.
Not awful at all. No.
And that was when I was searching for help and thinking, how do we carry on our lives like this without any extra support? Do people just get on with it and, you know, suck it up and have to do it, or what's, you know, how do everyone else cope? And, you know, you're floundering as a parent and thinking, my goodness, there's something wrong with me. Like, why can't I just get on with this? There's loads of kids out there. You go into the children's hospital and it's the norm to see lots of sick children, but actually, you know,
not the norm for you.
No, absolutely. No. So, you know, and then obviously we got in touch with you, and you have to find some kind of norm in it, but I don't think you can go through what we're going through without having some element of support, because it's just so hard.
Absolutely. And I think everyone watching tonight will, you know, understand that and have that empathy with you. And that's why it is so important to actually acknowledge, you know, the need for support sometimes. And it might be a bit later on down the road, like you said, when it was quite often families will say to us, as soon as, you know, my child was diagnosed, it was head down, I just have to put my energy into this. It's later on down the road where you come home to try and have whatever a normal life is, and you need someone just to sort of bounce off, and just someone to listen. Really important.
Absolutely.
We're coming towards the end of the session tonight. There's just one thing I'd like to end on. There's someone contacted and said, I would like to know where the main effort is required in order to improve the outcome for children diagnosed with a brain tumour. As volunteers, should we focus on raising awareness for earlier diagnosis, or is it more important to raise funds that can be ploughed into research? How can we best help you beat this horrendous disease and prevent more children and adults and their families from suffering? And David, I'd just like to pose that question to you.
Yeah, I think I've been thinking about this quite a lot, and I know that the Brain Tumour Charity and the other brain tumour charities are looking at this. I think you have to divide research impact into what can be done in the next 5 years and what might happen beyond that. Because a lot of basic science research is really testing things that may take another 5 or 10 years to come to fruition. And there are things that need to be done in the here and now that improve the outcome early. And I think awareness has actually already started to work. So the awareness campaign has raised awareness, not only of diagnosis, but it's raised awareness of brain tumour. And your charity, with its name, illustrates that. I think it's raised awareness in government circles amongst the major cancer charities. It's raised awareness in the public. Now people have got the Head Smart cards. So these are really important steps. I think at a technical level, however, it needs to raise awareness in the NHS systems to make sure that the scientifically justifiable developments are put into place fast. And I might give an example. Every child with a brain tumour or an adult with a brain tumour needs to have a piece of that tumour examined scientifically. Now, every hospital will examine it under the microscope, and that's a visual inspection of the tumour. But not every hospital has access to the biological characterization of that tumour within a week of diagnosis. And I think if we had that, there's enough information out there to tell us to manage people differently with that information. But at the moment, we don't have that available everywhere across the country. Some hospitals have one thing, others have another. There are systems, for instance, in Germany, where you send your tumour sample and they give you a comprehensive analysis from the biological perspective and reply within the fortnight. Well, we don't have that in this country. And I think that's a one priority, to get that delivered to healthcare in the next 2 years.
And that leads me very beautifully actually onto the last question I was going to ask you, is about where do you envisage the future of treatments for paediatric brain tumours? Is that what you just said?
Well, that's one aspect. I think there are 3 treatments for brain tumours. There's surgery, there's drugs, and there's radiotherapy. We're not going to be doing without surgery, and we won't be doing without radiotherapy. And we will need to be working with new and improved drugs. So in the area of surgery, we want to enhance its effectiveness and minimize its risks. So at the moment, we do surgery on everybody at the beginning. There are some risks of doing it at the beginning, which we would like to reduce. But we need to know the diagnosis before we can plan the treatment. And so doing a biopsy is something that has to be done. If we could actually make a diagnosis on imaging, then that means we wouldn't need the biopsy, and we could plan the surgery later sometimes, although there are risks. As far as radiotherapy is concerned, treating the tumour and not the brain is really important. So proton therapy and other highly focused techniques such as IMRT and therapy delivered in an arc can be very, very effective in hitting the tumour and missing the brain. And in childhood, that's very important. And we need to be rational about our use of these things. The story in the summer did actually include a lot of misinformation that caused great confusion for people because of the complexity of the topic. But the UK is the only country in the world that has made arrangements to deliver proton therapy to every child who needs it for the last 3 years. The only country in the world that's done that. Everybody else, it's by chance or idiosyncratic as to whether you get proton therapy. But that didn't really come across in the summer. It sounds as though we were denying people. But actually, everybody who needs it can have it. The argument about craniospinal radiotherapy is a scientific argument that is not at the moment accepted. So I think radiotherapy is going to continue to be used. It must be used in a way that's maximally effective and minimally damaging, because it's a very important treatment. And then drug therapy, I think there are 2 things: new drugs and targeting drugs. So new drugs are being invented to target new receptors that may change the tumour's behaviour, and they are already in development. And then getting the drug into the brain at a dose that's effective whilst minimizing the side effects from the rest of the body is really, really important. And the story that we've heard about Deborah and her child having chemotherapy and long periods of time, a lot of the time spent in hospital was spent dealing with the side effects of the drugs. If we could give those drugs to the brain in a way that avoids the side effects, then that would be a much more acceptable way of delivering drugs. So I think that's a big emphasis for the future.
Absolutely. And with proton beam therapy, we're due to have 2 centres opened in the UK in 2018.
Yeah, so that's definitely going to happen. The country's committed to that program,
Yes.
but we're already giving proton therapy to everybody who needs it right now in 2014.
Yeah. Mm-hmm. Thank you very much, David, for your really detailed response. I really appreciate it. I'd like to come to Deborah and just ask you, Deborah, if there would be one thing that the field could do, the charity could do, to make things better and support families much more, what would it be? On the spot, sorry.
Yeah. Well, I think, I mean, we're right in it at the moment in terms of the late effects and I guess the longevity and siblings, family as a whole, treating the family as a whole, and that's a really big thing. You don't go through something like this and come out the other end unchanged. And I think often, briefly, people are so relieved for us to see that Ella's scans are stable, that at the moment things are well, but the reality is they have no idea that she's so changed, and the real damage that's been caused, and that how that leaves us as a family, kind of trying to find our feet again around it. And I guess that for me is the biggest thing, because that's exactly where we're at the moment. And I think you leave hospital, and that's all you want to do is leave hospital and get home, and then you get home and you think, oh my goodness, now what? And you've been in hospital for so long, and it becomes a very safe place, and home becomes actually, you're now living in this big bad world out there where how on earth do you manage it all, I guess.
And like you were saying before, that actually it's very difficult when some charities and organisations withdraw their support actually at the point where you probably most need it, where you're feeling so vulnerable and so fragile, where you don't have that safety net of having a hospital. And we find that with a lot of families that get in touch, where, like I said, if they want to watch and wait, or they finish treatment and they're back home, that's where you're left to manage a situation which is, dark and confusing and really complicated, and it's scary.
Yeah, absolutely.
Thank you, Deborah. I just want to come to you, Michelle, finally, to ask what would be the single thing that you would like to see developed, changed, to be able to support families in a much more a specialist way, really?
I think it kind of leads on from what Deborah's just said, actually, in terms of this kind of what happens next after treatment. And I know you and I have been talking about this in terms of getting charities working together. So there's lots of charities out there, both for children's cancer charities in general, as well as specifically for brain tumours. And if there's such a scarcity of resources, then I think if we can work together, if we can look at what families need, ask families what they want, see what we can do in terms of sharing resources and working together and working forwards, then I think that for me would probably be answering some of the biggest questions and kind of service gaps that and a lot of the questions have reflected that have been posted on Facebook as well. So I think moving forward, I think that's what we need to do. We need to be looking at pulling our resources all together and seeing what families want and seeing how we can address those needs.
Absolutely, it's sharing good practice, isn't it? And I think multidisciplinary working, I think, is the way forward for definite. Just thank you so much, all three of you. I really appreciate you joining us tonight. It's been very interesting, and I'm sure we'll be doing this again at another time. What I'd like to do is to ask about, just to say to those watching tonight, that we do have our supported information line, which is open Monday to Friday, 9 till 5. If you have any questions or anything you'd like to discuss, and our number is 0808 800 0004. And also questions that came in tonight was about accessing resources for children that are age appropriate, and we just want to remind you about Jake, who's our new online animation. He's absolutely gorgeous. I'd like you to invite you to go and watch him on our website, and they are animations that address scans, surgery, and about treatments, and the importance really is for children to access it and watch it in a really safe environment and in a safe way, and for them to look at what is probably really scary for them, but for them to watch it in a safe way, and so we really invite you to go to our website to watch Jake. Thank you once again, everybody. We'll now sign off, and I look forward to seeing you all in the future. Thank you.
Thanks very much. Good
Thank
evening.
you.
Melissa.
Take care.
Bye.
Bye.
Bye.